A number of justifications have been suggested for high drug prices, and the main one that the industry emphasise is the high cost of research and development. And just as we were walking up the road from lunch, we were talking about, is it $1 billion per new drug? Is it 3 billion? What is the number? So the manufacturers would argue it's getting increasingly expensive to develop these drugs. That's why we have to charge high prices. They would also argue that there are benefits to patients still, and maybe these benefits are particularly valuable in patients where we can't do much for them just now, so just to be able to do something has a particular sort of extra value. The other argument that's put forward by the industry is that market forces, we were talking about that earlier today, demand and supply, will settle prices to reasonable levels. So the idea here is a new drug will arrive, there'll be a high price, but quite quickly other drugs come along, the price comes down. And there is some evidence of this, but it's not nearly as marked as you might imagine. And the final argument they use is if you control price, you stifle innovation. Now, that does sound really threatening, because if we control prices, we're going to get less innovation, we get fewer new drugs. It's almost as if medicine stops advancing. All of these justifications are heavily contested, particularly the first one about the cost of developing new drugs. Yes?
I wanted to say that there are some reports which indicate that pharmaceutical companies spend more money advertising than even on research and development. So this is just an exchange.
Yes. I think they call it broader marketing. Advertising sounds just a little bit, I don't know, but yes, they do. They do spend a great deal. And so that makes it sound a bit hollow, the claim that we must charge high prices because of the research and development cost. You could then say, well, don't spend so much on the marketing. If these drugs are so valuable, maybe it's not difficult to tell people about them at low cost. Yeah, I think that's true. There's also an argument, does the causation, do high prices follow from high research and development costs, or is it the other way around? We have the high prices first of all, and that makes it attractive for companies then, if they can get high prices, to invest more in R&D. So it's not at all clear, that argument. There are a few reasons why, specifically in the US, prices might be high. For example, Medicare, that's the federal program that provides healthcare to the elderly. Medicare are obliged, in most areas of healthcare, are obliged to purchase the drugs. There's a set discount, but not a very high one, and they can't negotiate the price. The price is the price for them. Now, in that sort of situation, it's quite a strong incentive for the manufacturer to set high prices. It's also the case in many states in the US. The insurance coverage must include these cancer treatments. And so if there's some other payer, that means you're going to get a bit less resistance from the consumer and the patient, because the insurer is going to be picking up the cost. And the other argument is that the Affordable Care Act was successful. I don't know if I can say this. I hope Donald Trump won't catch this lecture in a few months' time and he'll start tweeting about me. But Affordable Care Act seems to be quite successful in bringing many million more patients into the protected area of insured coverage. And of course that adds to demand. And with added demand, that drives higher prices. Interestingly, in this article, Ramsey in Health Affairs, he suggests that a really important reason for higher prices is that the cost of genome sequencing has gone down. I think, well, if the cost of genome sequencing has gone down, doesn't that reduce the costs of development? And his argument is that it's making it likely that your opportunity to market your drug is getting shorter and shorter. Because this particular important element of research costs has gone down, that's encouraging a lot more activity, and so drugs are then coming along faster. So any new drug you've got to market to yourself for a shorter period of time. And so what you're going to do, well, let's charge as high a price as we can, because quite soon I won't be able to sell this drug. It's quite an interesting argument, quite subtle one. Okay, the two case studies I want to talk about. The first one I've entitled A Pharmacological Success Story and a Decision-Making Challenge. I could have maybe said a decision-making nightmare. HCV, hepatitis C virus, was first identified in 1989, quite recently. Everybody sort of knew it existed before, and they just used to talk about non-A, non-B. But they actually identified it formally in 1989. And quite quickly after that, treatments started coming along. Interferon was approved in 1991, then ribavirin and interferon 98, then pegylated interferon 2001. And then it went quiet for a while. And I should point out that these treatments, ribavirin and pegylated interferon, work, but they're not great. Maybe 50% clearance rate of the virus, and with quite a lot of adverse effects and quite a tough treatment regimen. So then, telaprevir and boceprevir came along, approved in 2011, fairly closely followed by sofosbuvir and cimeprevir. And it was particularly the former, sofosbuvir, that really changed things. And then we've had more and more approvals. I won't read them all out. And we've got more in the pipeline. And there's been various ones where they were developing one and they say, no, I'm not going to bother. These existing treatments are so effective now, the new ones, that by the time my drug's ready, there'll be no one to sell it to. And so there's been quite a few have dropped out of the pipeline. So Hep C, slowly progressive disease of the liver. About 80% of it's mild disease, but in more extreme end of the spectrum, you've got very serious health problems, liver failure, and primary liver cancer. Lots of genotypes. And of course, this drug came along. Just take a tablet a day, virtually no side effects for anybody. Maybe clears up in 12 weeks, maybe 24 weeks. And just give me $1,000 for each tablet. Now, I think if they'd called it $999, they may have just got away with it. But 1,000 was it's just too sort of, it rolls off the tongue too well. You know, £1,000 a tablet. UK price actually £400, but doesn't sound quite so exciting, £400. I'm not sure the Japanese price. Probably quite high, but not nearly as high as the US price. So, what I want to talk about is how did the UK make a decision to say yes or no to sofosbuvir and indeed all the other virs as well. Well, what we do is we start by thinking, what are the current treatments? So at the time when sofosbuvir was introduced, these were the treatments. partly depended on which genotype you were, also issues of whether you had HIV co-infection. But probably the most common treatment was pegylated interferon plus ribavirin, but just recently, telaprevir and boceprevir had been approved. And so the combination of telaprevir and pegylated interferon, ribavirin was, for example, being used. So that was the setting, and so you then got the new drug coming along, and what you want to do is compare what will change if we introduce the new drug instead of the existing treatments. So, if you like, the decision problem, a very standard way, if you've probably come across it, the PICO format, P population, I intervention, C comparator, O outcomes. Population, adults with chronic hepatitis C. The intervention, well, initially, when sofosbuvir was being considered, it was in combination with pegylated interferon and ribavirin, or in combination with ribavirin. Comparators, well, as I say, probably the main comparator, pegylated interferon and ribavirin, and then there's a possibility of telaprevir or boceprevir. Okay. So what do you... Doesn't want to advance. No. So what do? We're trying to calculate cost effectiveness. And this is a measure, if you like, of value for money. What are we getting in health terms, improved health, for the money spent? And the heart of this is to calculate something called the incremental cost effectiveness ratio, or abbreviated to the ICER, incremental cost effectiveness ratio. And so in this case, the incremental cost effectiveness ratio is the cost of the new treatment. So SPR would be sofosbuvir, pegylated interferon and ribavirin, less the cost of existing treatment, pegylated interferon and ribavirin. And in the bottom line is the difference, the health gain or change in health, the QALYs that we expect with sofosbuvir, pegylated interferon and ribavirin, minus the QALYs we would have expected if we just used pegylated interferon and ribavirin. So in the top line we've got the change in cost, which we anticipate will be an increase, and the bottom line we've got the change in QALYs, or our measure of health improvement. So how do we calculate QALYs? Well, QALYs are estimated by weighting the time patients will spend in different health states. So in this condition, for example, patients move through different health states as the disease progresses. They spend a certain amount of time in each health state. And we weight the time they spend in these health states. We're weighting it by a measure of their health status. The idea being that it's better to be in a mild health state than a more severe health state. And we want the weight to reflect that. To calculate the costs, well, the cost is a combination of the cost of treatment, so that's the sofosbuvir, pegylated interferon, ribavirin, but also the costs associated with being in any particular health state. So these patients, they don't just get treated, but over time they're going to be in different health states and they're going to get all sorts of other treatments as well. We want to capture that as well. So what we need is a model to predict what will happen to patients with current treatment and compare it with what will happen with the new treatment.